Hello, everyone. We're going to begin in about a couple of minutes. So I just want to let everyone know that we are live streaming this this meeting on YouTube. So if you do not want to be seen on YouTube, your screen, you can just stop your video. And I also request everyone to please mute yourself so that there's no background noises. All right.
Ahora sí.
We still have some more people joining us. We can start soon. All right, so welcome to our October general meeting. Thank you very much for coming in tonight. My name is Rovina Nimbalkar, and I am the Executive Director at NAMI Santa Clara County. I'm going to give you some updates about NAMI Santa Clara County, what's going on. So the first thing is that we had our NAMI Walks Your Way Silicon Valley this past Saturday on October 10th, which was a huge success. And it was also the World Mental Health Day and the Day of Hope as celebrated at NAMI. And the NAMI Walks in general is the biggest fundraiser at NAMI Santa Clara County for us. And we're very happy that we've raised over 202. And I would like to thank all of you for your support and advocacy. Our goal for the fundraiser is $270,000, and we are keeping our fundraiser open for the next 60 days so that we're able to meet our goals and continue providing services that the community deserves. So again, thank you very much for all those who participated and all those who supported for the NAMI Walk. Some of the program updates. All our programs have been virtual since the shelter in place. Our warm line is up and running from 10 a.m. to 6 p.m. Monday through Friday by phone and email. We have after hours of family support, which is available on evenings and weekends. Our support groups are all listed on our website, which is www.namisantaclara.org. And you can see the schedule for all the support groups on our website. The family to family education class is going on right now, and the next class is going to be in January. If you need more information, you can call the warm line. The peer-to-peer class are going to have the graduation next week, and the next class will begin in January. Provider education class is actually starting on October 16th. The next FaithNet training is on October 29th from 11 a.m. to 1 p.m. And if you do need more information, do call our warm line number. They'll be able to answer all the other questions about our programs as well. And our community peer program continue to match via hospitals and self-referrals. So we are actually doing really well in this pandemic by providing all our services virtually and still continuing to do the work that we do. And thank you, all of you, for being so supportive. So those are some updates from me. I'm going to hand off to Bev Lozoff, who's the co-president of the board at NAMI Santa Clara County, to introduce our speaker for tonight. Over to you, Bev.
Okay. Good evening, everybody. I can't believe that 180 people registered to listen in on tonight's presentation. I don't think 180 people will actually show up, but that's a lot of people. I mean, if we have 100 people, that's wonderful, because from the convenience of your home, you can listen to a top-notch speaker on a very important topic. It is my pleasure to introduce tonight's speaker, Dr. Leanne Williams, who is professor of psychiatry and behavioral sciences at Stanford University School of Medicine. Dr. Williams will be presenting personalized treatments for mood disorders. Through the advancements in neuroscience, neuroimaging, technology, and digital innovation, researchers have been able to better understand the brain, detect mental disorders, tailor interventions, and promote wellness. Dr. Williams will discuss the first taxonomy for depression and anxiety, which quantifies 6 brain circuits, helping pave the way for precision diagnostics, prediction, and treatment. Through this approach, she is developing a standardized way to measure circuit dysfunction tailored to each individual. Dr. Williams is the founding director of the Stanford Center for Precision Mental Health and Wellness and of the Stanford Pan Lab for Precision Psychiatry and Translational Neuroscience. She is also associate chair of Translational Neuroscience in the Department of Psychiatry and Behavioral Sciences and Director of Education and Dissemination at the Palo Alto VA Mental Illness Research, Education, and Clinical Center. Prior to joining the Stanford community, Dr. Williams was the founding director of cognitive neuropsychiatry and directed the Brain Dynamics Center at Sydney Medical School. And you will definitely detect an accent, Sydney, Australia. Dr. Williams completed her PhD at Oxford University. Please join me in welcoming Dr. Williams.
Thank you so much, Bev, for that wonderful and generous introduction. And also thank you for the invitation to Rowena. I will share my screen. So let me know if you can't see that, Bev. All good.
Sorry, I muted myself. I definitely can see your screen.
Well, thank you again. It's a great pleasure to have this opportunity in these circumstances to connect with so many of you. I hope that you're all doing as well as possible in these times. I do want to specifically congratulate NAMI. It's such an incredibly important resource. Congratulations on the walk and also acknowledging World Mental Health Day. So what I'll talk with you about tonight will aim to allow plenty of time for discussion and to make sure I cover topics that may be of particular interest. But I'll be talking about some of the work that we have done through my center and also having a little look at where we hope to go for the future. So this, when I talk about my center, it's the Stanford Center for Precision Mental Health and Wellness. And what I hope to communicate tonight is a sense of hope about where we are going in terms of mood disorders and bringing the insights that we're gathering from understanding the human brain and how that human brain connects to the experiences that we all have. So first of all, I wanted to share a couple of contact points, and certainly we can come back to these at the end. I'm anticipating questions you may have. So the first one, obviously it's unusual times, so we're not doing as much research as we normally would like to, but we have one study opening up that is known as the Connectome study. And that's a link for those who may be interested in the study. And it's going into detail about the 6 brain circuits that I'll be talking about this evening. The second one is the contact for my lab. So that's any time that you may have questions or want to find out about research that's available, that's the link. And the general contact for the center is the one below, the PMHW. We aren't currently running as a clinical service, although that is something I'll be talking about for the future, for next year. But this is the phone number for the mood disorders clinic that is within my department. So to start with, setting the scene, obviously we all know about the toll that mood disorders take. And I'll be focusing in particular on depression and anxiety, but we do study the broad spectrum of mood disorders and anxiety disorders. So if we look at the snapshot of impact, we are talking a lot of impact on people's lives. And bear with me, I'll go forward one slide. So across the world, the rate of suicide is alarming and unacceptable at 1 million. I have had a loss of a loved one to suicide myself, and I understand the toll that on the individual and the families. And obviously what we're wanting to do is do better in terms of the impact on people's lives in terms of disability and obviously loss of life. And we want people to be able to reach their full potential. So the way we think about it is in terms of what we think of as building a platform for precision medicine for psychiatry, and in our case, applied to mood disorders. And this is something we take for granted when we seek care, healthcare in other areas of complex and stigmatized illnesses. So maybe for a heart condition, for diabetes, for cancer, we have a way of being able to see our doctor or health care worker and get information about what may be going on. Do we have a broken bone? Do we have elevated insulin, and do we need particular types of treatment? And this is what we're wanting to develop for depression. So the way that we look at it is, first of all, this concept of biotyping, which is moving from what is currently a kind of very broad way of thinking about a disorder like depression, where we think of a kind of umbrella category that is the diagnosis. What we're wanting to do is really try and detail the specific subtypes and how they're experienced by each person. And that is what we call biotyping. That then gives us a way to do more targeted trials, and that's to look at what treatments will work for that person because of their particular biotype, and then how can we develop new ones. So this biotype guided trial approach, I'll show you some findings we're excited about that help us know, like, if you have a particular biotype, what treatment might you respond to? And then we can move into the clinic. And our ultimate goal is, how do we do better for individuals experiencing these disorders and for their families? So when I'm talking about biotyping, I'm mostly talking about and kind of anchoring this understanding in taking very high resolution images of the brain. So it's an MRI for the brain in action. However, I certainly don't argue that that's the only way to understand depression or other mood disorders or ourselves as individuals. So what we're focusing on is understanding the brain as the organ of interest. When we're talking about disorders such as depression, we think of it as on a continuum where we have brain function that can guide us through stressful situations, and sometimes can get stuck. But we also think about these other levels, and we acquire data across these levels. So what's the experience that you're reporting, and what is it that you what is your subjective experience each day? We do, whenever we can, take information about genetics and increasingly inflammatory marker information. But this is the anchor, this brain circuit level. We also look at physiology. So how is your heart rate? How are other physiological indicators? And then lifestyle, behavior, the whole context. And in many cases, we're asking about life history as well. So in this approach, this is kind of cartoon schematics of how we think about it. So as I mentioned, right now, the diagnosis, as many of you would be aware, relies on asking questions about what symptoms are being experienced. And that's obviously important. And it is information that's needed, and information would be needed for other areas of health as well. However, what that doesn't give us is what's going on in terms of the underlying biology, or what might be giving rise to two different symptoms. They may be coming from the same source, or there may be multiple different ways that the brain can become disrupted and lead to symptoms. So what we're trying to do is understand this individual variation, and then recognize that no two brains are the same. So the way that you experience depression is going to be unique to you. And we measure these biotypes, as I said, anchored in the brain using the high resolution functional MRI. So let's have a look at these circuits. So as Bev mentioned, there's 6 of them. And when maybe if I go back one step, when someone's in the scanner, we give them, it's kind of like a stress test for the brain. So they start off just at rest, and then we give them different tasks to do. And that's a way of engaging these different circuits so we can measure and quantify them. So the first one we see when the brain is at rest, it's called the default mode. You may have heard of it. It's where it's almost like literally the default state. So it's like your brain is the equivalent of your car being in idle when you're in neutral, when you're not engaged in a gear. So we need to be in this state to self-reflect and switch from one brain state to another. So when our brains can switch into this default mode easily, backward and forward to focus, that's a good, optimal kind of flexible function. What happens in some forms of depression is they'll get stuck in that mode, and it'll cause potentially too much self-reflection, so too much focusing on internal worries and internal concerns and negative thoughts. And that can disrupt sleep and many other functions. The green one is one we call salience, and it is one that responds to important cues or signals. So inside ourselves, like pain or hunger, it also picks up salient cues in the environment, and it guides our brain to move into a different state. So it's this salient circuit tends to get disrupted in particular types of anxiety that involve kind of anxious arousal. It may be anxious about being around people, or anxious about too much sensory stimulation. You'll see this circuit will get stuck. The orange one we call negative affect, or sometimes you'll hear it called threat, or you may hear it called the alarm mode, or fight and flight even. So it's the one that has 2 modes. It switches on automatically when we are detecting a threat or a stressor. And then it's one that we actually can consciously switch on to regulate our stress. What happens when we have a trauma is it can stay in alarm mode. So if we have ongoing stresses and traumas, it'll keep getting triggered and sometimes stay on. And that's a feeling of being hyper alert and vigilant and sometimes the symptoms that overlap with PTSD will be experienced. This one, the purple one, is called the reward circuit, sometimes positive affect. And it's one we respond to positive emotions, social connections, social cues, anything that motivates us to do particular actions in our life, one we need to motivate our behavior. It's one that's under a lot of stress, for want of a better term, right now, because people have such limited social interaction. And this attention one in yellow is one that's involved in maintaining our focus and our attention. An important illustration of how they work is when the default mode, the blue one, is engaged and we're kind of free associating and relaxing, the yellow one will be suppressed. And then when we need to focus, the yellow one will be relatively more engaged. And the same for the next one, which is called cognitive control or central executive. This one's even more focused planning and focused executive function. So,
Dr. Williams, I would hate to interfere you. Is it possible for you to speak a little louder? I think there's been some low volume.
Okay.
Thank you.
I will do that. Is that better?
Yeah.
Okay. So these 6 circuits are ones that are present in the healthy brain. So all of your brains will have these. They are coordinated sets of different regions that cooperate together. And we need them in the same way that we need, for example, blood pressure or heart rate. So they'll vary to different degrees in everyone. What's happening in depression, as far as we are understanding it, is one or more of these circuits will get relatively stuck and needs to be unstuck. There are certainly more circuits that we're discovering in the human brain, but these 6 are the ones that have been most studied so far in relation to depression, anxiety. And there are some very large-scale efforts that we are part of that are detailing these more and more. So one you may have come across is called the Human Connectome Project. So it's analogous to the Human Genome Project. So in this case, mapping the human brain, and our studies are then applying that to depression, anxiety. So if you look in depression, anxiety, these are the 6 ways that those large-scale circuits can be disrupted. And I refer to them as biotypes. They tend to be characteristic of individuals. And the analogy that I draw to other areas of medicine, so if we go back, we are here characterizing for now 6 types, and I'm sure we'll find more. But we can think of them in relation to, say, cancer medicine, where more and more we're being able to, with imaging and genetics, identify important subtypes that help us guide treatment. And similarly in cardiac medicine, heart health, it's really only been the last 70 years that we've had a detailed mapping of the heart, and that helps us understand what types of too much heart rate, too little, etc., relate to the different health conditions. So to move to treatment, what we very much want to do is change this situation where typically only 3 out of 10 people are recovering on the first antidepressant they try or the first treatment they try. We want to at least double that, and our initial results are promising to suggest we can do that. And how the current situation works, as I'm sure many of you are aware, we necessarily must rely on a kind of trial and error. And so phenomenally well-intentioned and dedicated clinicians that do their best on the current information we have. So the idea is if we can add the biotype information, we'll be able to add more precision and increase the chance of choosing the right intervention the first time. So we are building on the clinical expertise by adding this biotyping information. So let's have a look at a few of the results. The first two are two large-scale studies that have been completed, and we're looking at the results for. One is of medications, iSpot-D. That is one that actually brought me to Stanford. It was an international study. The second one is a study of behavioral interventions. And then I'll give you a snapshot of a new intervention and then insights into where we're going clinically. iSpot ran across 5 countries. So I was over here in Sydney and I set up over here in Stanford, and that's what brought me across here. We had 1,008 people with depression in the trials. It was a partnership with many PCPs and psychiatrists. We brought people in before treatment, and then they had this biotyping imaging workup. They were randomized to what were the 3 most commonly prescribed medications in each country. And then 8 weeks later, we repeated the workup. So what we were interested in was just knowing about biotype help do better in knowing who's going to respond to what treatment. And here's some snapshots of what we found that give us hope that we can double the accuracy of who gets better. So the first one with this biotype 1, this default mode being stuck, what we found is people who do well on any of the antidepressants we've looked at tend to have an intact default mode. So that switching that happens is intact. And so here it gives us a way to pick out, select people who are not showing that default mode switching, who are not remitting, and offering them other treatments rather than waiting and seeing on the antidepressants. For biotype 2, we actually have people do this simple task where they're identifying emotions. So in this case, sad faces evoke the salient circuit. And what we find here is we can pull out even more specific responses. So this gives us a classification accuracy of 81%. Very specifically here, we can distinguish people who do respond to a specific type of antidepressant. So one that, like for example, a Fixor that has a dual action. And we can now also sub-select people who are not going to respond to that to then consider other options. If we look at biotype 3, which is the one to do with the overactive threat, we probe that with a different kind of emotion task. And here we have a 75% classification accuracy in being able to pick out responders to first-line SSRIs. So these are the people who do respond to, for example, Zoloft or citalopram. And that's important to know because they are typically very commonly used as a first-line choice. For the ENGAGE trial, so this is switching now to behavioral interventions. In this case, it was a collaboration with my wonderful colleague, June Ma, was at Stanford, now is at UIC in Chicago. We focus now on this question of, so if there's people who are not responding to the antidepressants, what might work for them? So we targeted or kind of focused in on people who were resistant to the medications, and in this case had a profile of depression plus they were seeking weight management support. And we tried a new behavioral intervention that June Ma has pioneered, which focuses on very active problem solving and behavioral activation strategies over 2 months. And we did the repeat scanning of these people in the study over baseline 2 months, 6 months, and 12 months. And we had a cooperative and collaborative structure. So we had PCP, we had a coach who helped with the problem-solving strategy, and then a management of any need for adding medication later in the trial. And in this case, we had 108 people who were randomized to receive the therapy. This is, I realize, a busy slide, so I'll walk through it. What was exciting in the findings, and these are being reviewed right now, is the people who did not respond to the SSRI because of biotype 3 were the ones who did respond to this therapy. And in this case, we found that the therapy for this behavioral intervention over 2 months, it actually rectified biotype 3, reduced the overactivation, and that was correlated strongly with the symptom improvement that was sustained over 6 months. So this was very encouraging. It's certainly by no means a straightforward intervention, but it is one that's available, can be available through primary care. So let's move now to how we're looking at novel therapeutics, trying to address this pressing question of people who are not going to respond to the currently available treatments. The one biotype that we find often does not respond to standard pharmacotherapy, and in many cases not standard behavioral therapy, is this biotype 4, which is where this reward circuit becomes underactive. So it's like a blunted emotion, blunted positive emotion. We think of it as anhedonia, so it's a loss of the normal hedonic experience of pleasure. This is an awful feeling of feeling grey and unmotivated, hard to move around. And what we're interested in here is, can we target this specific reward region that is underactive? So in this trial, which was run by Laura Hack, who's a fantastic psychiatry researcher in my group, we tried a medication off-label called pramipexole that's normally used for, say, restless legs, for some forms of Parkinson's disease, and in this case used a low dose version of this drug for 8 weeks because it targets that part of the reward system. What was encouraging, so these are our first 5 participants. What we're finding is, in this case, they specifically have that biotype 4. And we find here that after the 8 weeks, the reward circuit biotype is improving, so it's getting more engaged. And in parallel, the symptoms that associated with that flattening, these anhedonia symptoms, are actually getting better. And this was encouraging because we saw it in each individual person. Certainly by no means saying this is the answer, we need to follow it up, but it's a sign that targeting the biotype may be of use. And we have a story on this, which is shareable in Science magazine. And one of our participants, Mo, who's here in this story, this is Laura on the left, and Mo was incredibly open with his story. So he talked about how distressing it was, this experience of anhedonia and the reward circuit biotype. It was causing him to not be able to work, giving him thoughts of suicide, just losing hope. And after the first few weeks, when he started to get better, this was how he was describing. He said he could enjoy music again, the colour had come back into his life. So the experience of the reward circuit being engaged again. So of course, we really want to make this available to people and feel a frustration that it takes a long time to not only confirm these approaches, but to make them available clinically. But this is something we're actively working on, clinical translation. So the first thing we've done is advance a way to actually measure these biotypes in the circuits in a standard way. So similar to if you go and get an EKG or get a blood pressure reading, you know that the scores or the measures that come out of that reading are reliable, wherever you go to get them. And we needed to create a way to do that with MRI. So we have created these biotypes, we put them into a standard way of quantifying and having a normative frame of reference, and then being able to calculate scores. And that was the first step to make it clinically available. And we are working on a way to generate reports that provide that equivalent to lab test results. So here you would, for example, in the case I was showing you, you can see a kind of before and after of scores on those biotypes. You can see them in pictures, and then you can get a profile of all the other information that's important: symptoms, coping strategies, day-to-day quality of life. And so here you see for Mo, he had very, very severe anhedonia. It was causing a lot of distress. So we can now use that in an individualized report. And we could see his score on this biotype 4. He had that as the greatest fit to his biotype, which was the one we targeted. So I'm going to very quickly turn to a couple of other things, not to go into the detail, but just to say these are available as other forms of resources that we've been sharing because of the extreme situation we are all in with the pandemic. So we, in addition to the clinical activities, we've been wanting to disseminate the findings for how they may be useful for thinking about coping in this time, not only for the exacerbation of existing mental health impacts, but ones that may be created because of the situation. So here's one paper, but also on our website at this link under resources, we've been gathering the information we pull together. So we've written a number of white papers that talk about biotypes and how you might use this understanding just in day-to-day coping strategies. And here's an example of the full list of them on that website. We've also written a couple of other papers on expanding it, like thinking about what's the impact of the lack of social connection and so on that are on this site. And we also list all the resources, including the wonderful resources of NAMI. And some scalable opportunities such as the apps that are recommended for dealing with stress, anxiety, and depression. So the last slide I'll end off with is what we're on track to launch in 2021, and that's thanks to Laura Hack, who will be the lead physician, psychiatrist, clinician scientist, who will lead a new clinic called the Translational Precision Mental Health Clinic. We are taking those biotype methods and actually incorporating them into new clinic workflows so they can actually be ordered and referred for. So that email link there will be the one to express interest, and we'll be keeping people updated once it opens. And I will end there and thank everyone and open to questions, and I can go back to the slides if we need to refer back to them. But thank you very much.
Thank you so much, Dr. Williams. That was very insightful. We do have a lot of questions, and so I'm going to ask you some of them. So let me begin, but I'm just going to open my sheet. Okay. What is your opinion about the use of Dr. Daniel Amin's brain SPECT scan by the psychiatrist in diagnosing a brain disorder?
Right. So Daniel Amen uses, as you mentioned, a technology called SPECT. It is not the same as the functional MRI. I think the principle of what he's wanting to do and is doing in measuring information about the brain, I think is an important, like he's leapt ahead in that regard. Because I'm a researcher, I have to share what I think is an issue that needs to be considered, which is that there isn't yet peer-reviewed evidence on the technique. So it is based on accumulated knowledge through the clinics. And obviously it takes a lot longer to go through the process of having the peer review of the studies. So that would be the main difference of what we're doing. Plus using the high precision functional MRI.
Thank you. Thank you for answering. Okay. The next question is, I think you did provide some resources. How to deal with the stigma and raise community awareness on mental conditions? So that was the question.
Right. Do you want me to put that resource link up again?
Yeah, that'd be great.
Okay. So I would suggest this link, williamspanlab.com resources, and there we have listed more than I could show on this page, which is resources about addressing stigma, addressing social justice issues, tips for dealing with health issues, mental health issues in the pandemic, obviously the wonderful warm chat line and NAMI resources. Does that answer the question?
Yes, it does. It does. Thank you. Thank you so much. The other question, I think you said you would expand on this, was that what role do you feel trauma, diet, exercise, and other environmental factors play in mental illness?
Right. That's a fantastic question, and I could give a whole other presentation on it, but in summary, all of the factors of diet, lifestyle, trauma certainly are really important. So sometimes I think inadvertently we imply that by understanding the brain and imaging that that's the only answer. So I think of it as thinking of the brain circuits as being incredibly plastic, changeable, and being in some ways your best asset. They're very, very complex, and they rapidly change, as many of us know, as we develop from childhood. So as we go through childhood and then teenage years, the ones I talked about later, the yellow ones for attention and the red one for cognitive control, they develop right up into late teens, sometimes right through the 20s. What that means is that everything that you do, your experience, your behaviors, your choices, and exposure to negative trauma, as well as exposure to positive experiences, will shape how your particular brain circuits develop and wire. And that, I think, is really important to always keep in mind, because we know that for our physical body, right? We know if we do a lot of exercise and practice targeted repetitions, we can in some ways tone if we want to, or get fitter, or it is malleable. So that's one way of seeing that. What we are doing in understanding biotypes is wanting to identify, are there particular experiences that have the most impact? And one of them is early life trauma. So having negative trauma, so that might be neglect, it might be abuse, and having that occur as the brain is developing, rapidly developing, can really create vulnerability in some of the circuits. What I think is important about that is to know for learning in the future that there are ways to ameliorate that impact in children if we can provide a positive environment immediately to address the effects of trauma. For adults, it means knowing that some experiences you may be having and feeling like you're reliving the trauma are very real, because it literally means the part of your brain that needs to process the trauma is going to be struggling to do that. And we need to find a way to have the cognitive control brain work out how to resolve the threat response in brain terms. And that means finding the right trauma therapy to be able to do that. And again, the brain is plastic. It's just going to take longer because it's a consequence from childhood that's been repeated a lot of times. Probably the last point to make is the same way as if we're wanting to be fit with our heart. We may have a heart condition and we need to take medication, or we may need other forms of therapy. But we also know we need to think about our diet, our exercise, our lifestyle, and the choices we make. And to me, it's very much the same for brain circuits.
Absolutely.
That they don't exist in a vacuum.
Yeah. That's a great answer. Yeah, thank you. Thank you so much. I do have some questions here in the chat. Does a test like Genome Mind give any of this data or direction for treatment?
Right. That's a great question, and I didn't touch on it. So in the clinic that we're setting up, we will be including that information, not necessarily Genome Mind, but that type of information, which is certain genetic variants that have been implicated in how you might respond to different antidepressants, so pharmacogenetics. What we have found, because we have studied it, so in iSpot, the iSpot study I was talking about, we did acquire genetic information. What we've found is that it gives complementary additional information that's not the same as the biotypes. So one example would be if we see from the biotype that someone does respond to an SSRI, knowing about the genetics can help tell us which SSRI is likely to produce the fewest side effects and the best kind of match in terms of side effect profile and other considerations. So my hope for the future would be we would have both sources of information.
Right. Okay, thank you. Thank you for that. The other question is it good for PTSD and bipolar conditions?
The biotyping? So right now, we have not directly tested it to the level that I would want to. We have included people experiencing PTSD and bipolar 1. Certainly colleagues at Stanford are looking at bipolar disorder. Manpreet Singh's doing fantastic work. What we do know though is, as may be apparent from me describing the circuits, these circuits, because they're part of how the human brain is organized, they are implicated in these other conditions as well. So the threat circuit I talked about is disrupted in PTSD. So in that sense, even though I haven't directly tested them, I would expect them to be directly relevant.
That's great. Have you done any work with Lawrence Funk, MD, to see how biotypes are for ASD people with treatment-resistant depression? If so, what results have you found? Right. Have you found any people with treatment-resistant depression or any type of depression that do not fit those biotypes?
Right. Great question. So Lawrence Fung was, when we were in Preston, was just a few offices away from me. He's a wonderful researcher. We have not directly worked together. Certainly the way we've talked many times, so the way that he would think about the spectrum of like neurotypical through to like an Asperger's spectrum would be very applicable. Certainly in terms of the same kind of circuits that I'm talking about. Yeah.
And I think somebody asked about would this work on mania as well?
On mania, that one's been, to be honest, that one of the greatest challenges that I really would love to solve, and that is because it's very hard for someone who's in a manic phase to be able to be in the scanner. So I would anticipate that it would work, and it's really about I think the next advance in the MRI, where we're trying to make it a shorter and shorter duration scan, and that it's kind of getting faster with each new advance of the technology, and I think that will make it possible for someone where it's not distressing to be experiencing mania and then be asked to stay completely still for many minutes in the scanner.
Okay. Would you be taking volunteers for your future studies?
Absolutely, yes.
Okay, that's good to know. Yeah. How can one get this treatment and get tested at your clinic?
So for now, until the clinic's open, but ahead of that, the way to be able to get these assessments is through the research studies. So I could share, do you want me to reshare the link or maybe post it later?
Yeah, I think some of our participants are also asking for the resources and some of the slides. Would it be possible for you to share the slides with us so I can then share with everybody else?
Happy to do that.
That'd be great. Thank you.
So that on the slides, I think it's the second slide, has the contact information for expressing interest in the studies. And I think one consideration, because we're trying to get a very precise answer about the biotypes, there is one consideration that can be a limitation. So to mention it is when we take the first scan, we do need people to be not on treatment, and we don't want for people to go off treatment and cause risk. So that's a limitation. Sometimes it's before people have started, they will come in and do that scan. Sometimes it's because there's a planned with their doctor, planned pause or change, so we can do it then. But that is the current situation. In 2021, we'll be relaunching our treatment studies. So they're the ones where we're looking at these novel therapeutics with Laura Hack. And then as soon as we can possibly get this into the clinical system, into the medical record system, we will be able to open the clinic, which will mean not for research purposes, but coming in for clinical purposes.
That's good to know. Have you or your colleagues conducted studies on homeless people to see how homelessness would affect the outcome?
That's a great question. I have two aspects to that answer. So if I go back a bit in time, when I was previously in Sydney, we did include people who are homeless through a crisis mental health program, where there was a way where they could be offered to take part in the study, and we could provide transport support and so on. It is hard to set up because of the contact process. What we are doing in San Francisco and Santa Clara area is looking at how we can create partnerships with local community groups to make that possible, because we are aware that our access to our research is fairly limited. So we do want to address that, and we're actively working with several community organizations. So that's not an immediate answer, but we certainly are looking at the options.
Okay, that's great. How many biotypes can people have at one time? How does having more than one biotype affect treatment choice?
Right, that's an excellent question. So what we found is typically people have one predominant biotype. It doesn't mean it's all or none, but they do tend to have one that's predominant. There are times when we see a combination, and I can explain how it affects treatment. So there's one combination where the blue one, the default mode, will be stuck, and it is accompanied by problems in the attention and cognitive control, because they can't, once the blue one's stuck, it's hard to focus, hard to engage the others. In that case, that combination all points to not doing well on a standard medication. So what that tells us is we need to look at alternatives that may be outside of pharmacotherapy to be able to reinvigorate the circuits. And we have done one small study looking at transcranial magnetic stimulation, TMS, and we have found that to be effective. And we have a study that we wish we had been able to start, but we do hope that it will resume next year, which is specifically looking at that combination, that default mode cognitive control, and whether the TMS will be a different way to be able to engage and create. What it looks like is it will help those kind of cognitive fog experiences.
I was muted.
Okay.
Are biotypes related to Genome Mind saliva metabolic information?
That is a fantastic question. We don't yet know, but we are certainly gathering the information. We have collaborators and colleagues in Emory, Atlanta, who have started to look at this, and they find that inflammation acts as a stress, obviously, on the nervous system. So it may exacerbate something like that reward circuit anhedonia type. It may make that part of the brain more likely to be compromised. So I would be surprised if there's not a connection. And certainly we're interested, and that's why I want to gather inflammatory markers. We just started today actually a study that I didn't mention that is funded through Stanford under the priority for the COVID-19 studies to look at recovery from COVID and impacts on mental health and on brain function. And that's one of the kind of questions we have is the ongoing inflammatory process that may last for a little while actually disrupting kind of brain health and creating some fog and kind of that feeling of anhedonia.
Are you starting an IV and injecting anything into the patient prior to resting and task the MRIs?
We don't do any injection prior to scanning. So if we were doing a different kind of imaging technique, so say one called PET or positron emission tomography, that is where you need to inject a tracer into the bloodstream so you can watch the effect of a drug being metabolized. We're not doing that type, so there's no radioactivity.
Does the biotyping show who would benefit from TMS?
It's looking promising that it is. based on what we have looked at so far. So this study that will resume in next year, we hope, we'll be able to get at that in more detail, because what we're doing is focusing on people who have not responded to prior medications and are experiencing a lot of burden of illness. And so what we'll be doing is targeting that biotype and looking at the TMS, and then following up with 2 repeat scans. So that will give us a bit more information. And then I have wonderful colleagues in my department who are also looking at this question specifically in treatment-resistant depression to target that kind of default mode for treatment-resistant depression.
I do have one question that says, I spoke with you in 2019 at Stanford Mood Disorders Education Day, and you told me that they were developing meds for ADHD that are non-stimulants. I have bipolar 2, anxiety disorder, and have ADHD. The ADHD can't be treated because typical treatments make me have problems with bipolar aspects of my illness. And the ADHD makes me feel overwhelmed and I get so stressed that I become anxious, and eventually I get depressed too. The ADHD needs to be treated with new treatment. I don't do well with antidepressants. What is the status of non-stimulant ADHD meds? I'm a family member, a client, and an LCSW provider.
Right. Well, thank you for the question. It just sounds really challenging to have those experiences all together, and I absolutely recall the conversation. The study and the treatment that I was talking about when we talked in 2019 is one of the studies that we have commenced and we want to resume next year. So there are currently, so to backtrack a bit, there are currently no FDA approved ADHD medications for depression, but there are some that are used off-label, and that one of them will be one that we'll be studying, and it's called guanfacine, immediate release. So it's a non-stimulant, and it targets that kind of cognitive control circuit that is disrupted in both ADHD, and particularly ADHD with anxiety, and is disrupted in particular forms of depression. So in the study that we will resume in next year, that's the medication we'll be looking at in that study. And it's not one that I put a link up for because we're not currently recruiting, but what I would do is encourage people to express interest. And I recognize that it's obviously not going to be for everyone, these novel treatments. So part of the study is a very thorough clinical assessment and biotyping. So that's a kind of partnership between the clinicians and my center.
Thank you. There's a question, are there any treatments that do not involve medication?
In this case, the behavioral therapies, the one I talked about with the ENGAGE study, that one we found we don't find a specific effect on cognitive control, as in it's not specific to the problem solving, but it's certainly, there's an improvement in cognitive control over the 6 months of the study from being involved in a behavioral therapy. And that, I think, is the structure of it. And because it was combined with kind of healthy eating programs and kind of the participants wearing Fitbits as well to monitor physical activity, and all of that together certainly helped.
There is a comment about the medication guanfacine. I don't know if I pronounced it. They said that that somebody had a reaction to that, and then there's another comment that said that isn't it supposed to be taken only for a short amount of time?
So obviously there's a lot of detail. 1%, there's two forms of it. So there's one that's typically used for ADHD, which is an extended release form. So it's purposely designed to have a long acting course.
I see.
The immediate release one that we'd be studying in this case has a slightly different profile and is not typically used for ADHD. It was originally used for ADHD, but is no longer. So what we'd be doing is initially looking at the impact over 8 weeks. And what we want to know is, because it targets such a specific function in the brain and the accompanying attention experiences, we want to know, is it actually effective as a way of knowing what's the best path for developing alternatives.
Okay. And then another question, what percentage of each biotype occurring in your studies?
Excellent question. So they're not exactly equal. They're roughly equal. What has been noticeable, and we don't have a systematic way of knowing why, but we do have a very high proportion of people experiencing the anhedonia type, and a very high proportion of people experiencing the default, the rumination type. This is purely speculation, but we think because in some cases the available treatments have not worked for those people. So we're seeing more likely to have, as I said, speculation, but likely to have people come into the study who are seeking an alternative and hope for something different. If I go back to the iSpot study, which was the international study where we basically had many people coming in from PCP, it was much more even distribution because they were already coming in as a natural first visit for depression. So I anticipate that they're fairly evenly distributed, but depending on what study we're doing and why people are wanting to take part, we're seeing more of one or the other.
And then I have a last question. I think somebody wants to know if the biotyping can be applied to schizoaffective disorder. I know you answered about mania and bipolar.
Right.
If it's something that's applied to schizophrenia. Yeah.
So the answer, a couple of answers. So one is certainly the same circuits are implicated, not entirely. There's a few I didn't cover that are implicated in schizophrenia and schizoaffective disorders. The one I talked about called cognitive control, the last one, is implicated in schizophrenia. And then there are others to do with processing visual and auditory information that I didn't talk about. So when I was in Sydney, I did study different types of psychosis in a lot of detail, like from first onset through to chronic, and my collaborators are continuing to do that. So I don't have the most recent information at my fingertips, but it's certainly happening, like the use of imaging. And there's a wonderful project which has the acronym of BSNP, which is run by Carol Tamminga, Tamminga. She is overseeing a consortium which is also doing this biotyping, but for psychosis, so for schizophrenia, bipolar, and schizoaffective. And she's also had some very exciting results.
That's great. That's great. Well, Dr. Williams, this was really amazing. Thank you so much for your time. We really appreciate it. And the presentation and all your research and the studies are so inspiring. So thank you again from the NAMI Santa Clara County family. And it'd be great if you could share your slides so that I can share with everybody who had registered and who are here today. Yeah, so
Absolutely.
thank you once again for answering all the questions.
Absolutely. You're most welcome. And thank you for the invitation and for the wonderful work that you do.
Thank you. Thank you. Thank you so much. Thank you everyone for joining us today.
Bye.
Bye-bye.
Thank you.
Thank you.